All right, I'll just hop over there. This is a cool program because it can just simulcast to multiple channels.
It's great that it's on YouTube access also, because not everyone's on Facebook. So
Yeah, and that community has been growing, and I see people joining the room already, specifically from YouTube. So that is very cool to see. And let me double check Facebook. Yes, we are live. So let's not keep that anxious community waiting any longer. Let's start the show. Hello, everyone. Welcome back to Luncheon with the Experts, the Carcinoid Cancer Foundation and Neuroendocrine Cancer Foundation program. My name is Rain Bennett. I am your host this episode and every episode, and I am a filmmaker and a writer by trade that's been working alongside the NET community, I'll say, with CCF and NCF for... what year is it now? 2025? Yeah, going on 15 years, 12 years, 13 years or so, making all kinds of video content. I have lost count long ago, but live video series like the one you'll watch today. We do very patient-centric documentaries. We do treatment-based videos, et cetera, et cetera. You can find all of those on our video libraries, either on Facebook or YouTube, but they all share one singular mission, and that is to raise awareness and education about neuroendocrine tumors. That is what we are here to do. Now, if you are new to the community, the NET community, new to this journey, new to this show, the value of Luncheon with the Experts specifically, in my opinion, is twofold. One, the information and hopefully answers to some of your questions that you'll get from our guest expert, which is not me. But two, the shared experiences and shared stories from within the community. That is one of the most profound things that I have experienced and witnessed with the NET community is the strength and the camaraderie that exists. Patients, caregivers, support group leaders, specialists and doctors, like it's very, very strong. So I say that to say, and you might see people doing this in the chat already, introduce yourself, embrace the community. I assure you they will embrace you back. Tell us where you're signing on from around the world. We'd love to see the reach. Don't be afraid to ask questions. Sometimes the best answers come from the people right there in the community. They may have experienced what you are experiencing. That storytelling aspect, story sharing, is crucial to learning and growing in any journey, but specifically in a medical journey like this. So go ahead and start sending in your questions, and I will take a moment to introduce our guest today, who is a first-time guest to the show, which hasn't happened in a while, so I am very excited. Dr. Mintallah, a.k.a. Menna Haider. Dr. Haider, how are you today?
I'm great. Thank you so much for having me. I see a community from all over the U.S. and even abroad, so I'm so thankful for everyone's time.
Absolutely. So for those that may not be familiar with you, I alluded to this NET community already. What role do you fill in this NET community? Where are you from? Where do you work?
So I'm a medical oncologist, which means I use medications to treat neuroendocrine malignancies. And I work at Moffitt Cancer Center in Tampa, Florida, where we've already begun our summer. And I actually trained here as a fellow. So I completed my oncology training at Moffitt, and I was lucky enough to have access to a neuroendocrine tumor program, which is not common in training sites. And that was really my first exposure working in that clinic with my then mentor, Dr. Strasberg. Once I graduated, I started a small neuroendocrine clinic, but I really provided care for all gastrointestinal malignancies. And once my neuroendocrine clinic started growing, I pivoted and made this my career and dedicated my career to neuroendocrine oncology. Now, while we're housed in the GI department in our cancer center, we are a comprehensive neuroendocrine tumor program. So our team treats our patients with neuroendocrine tumors arising from any body system and throughout the biology, the spectrum of disease as well.
That's really helpful to know. So if I'm hearing you correctly, we can certainly field lung net questions, for example, today.
Yes, you're correct.
Okay. And I don't want to tangent too quickly, but is our lung net something that you treat there in the NET center, or is it more associated with lung cancer? I've seen it kind of go both ways in different institutions around the states.
Yeah, that's a great question because it can be confusing. So
Totally.
our team in the neuroendocrine tumor program treats patients with neuroendocrine tumor of the lung, but not neuroendocrine, not small or large cell carcinoma of the lung. So that
Got it.
particular diagnosis is treated by our thoracic oncology colleagues.
Got it. And a question for you, since you started specifically in NET so early in your career, can you recall what exactly it was during the early days that I guess intrigued you, that interested you in that specific path?
Yeah, I think what intrigued me keeps motivating me now.
Mhm.
So, when I say I'm a neuroendocrine oncologist, it appears that I'm very focused on one disease, but actually it's a big umbrella term. And so I'm engaged in care across many different modalities, really diverse diagnoses, different body systems that I have to keep up with and understand their physiology. So I really enjoyed that broad care still. And I feel that the neuroendocrine patient and caregiver community is incredibly engaged and well versed. I think a part of that is because it's an uncommon type of malignancy. And so in the general community, it's hard to find a team dedicated to that diagnosis. So it's puts patients in a position where they have to lead their care sometimes. But that translates into a really engaging relationship in the clinic.
Absolutely. Folks, before we get started, I see some questions coming in already, and the group size is growing fast for us, only being live 5 minutes, so that is exciting. Just a couple quick announcements. I mentioned that this is an NCF and CCF program, which is a partnership that has produced a lot of great things. Primarily, and I think one of the first collaborations between the two is the support line that you can find at ncf.net/support line. We will try to put that link, as well as any resources or information that Dr. Haider mentions today. We'll try to put those in the chat in the comment section, so you don't have to go open a web browser and try to search for it yourself. We'll try to make that easy for you. But the support line is very helpful for anybody affected by NET. So that could be support group leaders, patients, caregivers, anybody. If you have any questions or follow-up questions after today's show, again, that's ncf.net/support line. Another thing that we are collaborating on is a whole host of new video projects, which is exciting to me because that's really my specialty and where I love to work. Several patient documentaries and some bigger documentaries coming up. So I mentioned this a couple times on the show. If anybody feels like sharing their stories with me or thinks that they have a very interesting story to share, I'm always on the lookout for people to feature. And a very specific plug, I would really be interested in talking to any men. I have talked to lots of women. We have featured lots of women, and for diversity's sake, I think it would be interesting. My hunch is, and I may be completely off here, so forgive me if I am, is that maybe men are a little less likely or interested in sharing their story. I don't know. That's a massive generalization and assumption, but anybody is welcome, not only men, but I would love to talk to some men that have a NET story that they think could be helpful to others. Okay, let's go ahead and start the show. One last little best practice for you. Can't really handle super case specific questions in this format. So I know those of you who attend every week understand this, and I say this every week, but if you're new, asking questions in small generic chunks is going to be the best way to get your answer. There is no limit to how many questions you can ask, so you can ask follow-up questions. Dr. Haider may ask for clarification or more information, or her answer may spawn a new question. So you can always keep coming back, but try to ask them in little, small chunks. First of all, a personal question for me. Ron says, Rain, did you enjoy your trip to Colombia? Absolutely. My wife had her 40th birthday last week, 2 weeks ago. I've lost track. And yes, it was fantastic. And we ate all week long. All right, let's get into the show. Our friend Lisa Yen has a question that was pre-submitted. So let's go ahead and get to that. Thanks, Lisa. How are you? We'll talk soon. I lost it. Where'd it go, Lisa? Oh, we've got people from the Philippines today. I love to see that. Okay, so Lisa, on someone else's behalf, is asking, is there work being done on an oral somatostatin analog? SSA?
Hi, Lisa. It's great to take your question, and thanks for joining today. Yes, there is. And so right now, somatostatin analog is really the first treatment that we most commonly use for mature, meaning well-differentiated, lower-grade neuroendocrine tumors. And at present, the treatment is once every month, provided in a cancer center, an infusion center, as an injection. And so there are two developments or two modalities being developed. One is an oral pill, so by mouth, that is under your control at home. And the second is a subcutaneous injection, kind of very similar to the short-acting octreotide, which maybe some of our patients have used in the past, or like an insulin experience, where you self-inject or provide the medication to yourself every other week. So when we use somatostatin analogs, it's really a backbone of the treatment and a long-term treatment. And so having ways where it is less disruptive, you can travel more easily, you're in control of the medication, we anticipate could give a better quality of life.
When you first started your answer there, you said something along the lines of it's one of the first treatments. Is that how you worded it?
Yes.
Asking about SSAs. That's not exactly what you said, but more or less. Anyways, the question that I have, which is a big one, and it's talked about every week, so it might not be a very direct answer, but I want to discuss sequencing a little bit. From your perspective, and I know it's not a one-size-fits-all approach. How do you approach something like that in terms of sequencing? I also know it's very much in conversation and discussion currently. What's your approach to that? What's your stance, if you have one, on sequencing, and what does it depend on?
Okay. So I think first I would zoom out and talk
Sure.
about where we're focusing this discussion is for our patients with well-differentiated tumors that are lower grade. So it's not going to apply for neuroendocrine carcinoma, for example.
Got it.
And because of the indolent nature of some of these tumors, meaning they are slow to grow, and the chronicity of treatment, we want to match a treatment that has the least side effects, the least disruption to quality of life, but very good effect in tumor control. And at present, when we cannot offer surgery, for example, and we want to begin treatment, a somatostatin analog really is a very reasonable first step, because it's unlikely to disrupt end organ function, for example, like your bone marrow efficiency, liver function, kidney function, etc. And thereafter, we pull in other treatments when we are seeing a breakthrough through that control, so tumors that are growing. And at present, we still are in a position where each tumor can be treated differently based on where it's grown, how you're feeling as a patient, what other health concerns we have, like, for example, high blood pressure, high sugars, diabetes. But at the same time, there's a lot of effort to try to really sequence care to better understand. We should be looking at, for example, a radiotherapy like PRT after somatostatin analog, rather than only focusing on a personalized approach. And I think some of those signals are already coming out, for example, in comparing PRT to a pill called everolimus, and trying to understand after somatostatin analog, perhaps PRT would be the next best step in the correct setting. And so, sequencing can really be personalized. Another great connection in clinic is that I have a different conversation with every patient in every room, and we can really personalize how we proceed with treatment.
Absolutely. Thank you for that. I appreciate it. Also, a special shout out to Brigitte from Bordeaux, from France. I believe that's the first time I've seen your name. So welcome from France. Love to see you. Next question comes from Len. Len says, hi, 46-year-old male has been on 60 milligrams of cabozantinib for 2.5 months. Hair, eyebrows, and eyelashes have turned silver white and have dramatically thinned. The question is, will this get worse and or become permanent? And if allowed, is there a safe hair dye? And if so, what ingredients should be avoided? So a few questions there.
Great. Actually, an opportunity to discuss cabozantinib a little bit. So Cabozantinib is a pill taken at home. It acts differently from chemotherapy pills. It's a TKI, so it acts on pathways of how tumors create a blood supply and respond to growth factors. And it's actually not new to the oncology world. It's been used in other malignancies, but more recently, it is now approved for the use of treating neuroendocrine tumors. And what's unique about cabozantinib is an underserved population are patients with lung and thymus neuroendocrine tumors who are not always included in clinical trials, but cabozantinib did have a dedicated population with lung neuroendocrine tumors, small bowel and pancreas as well. And another unique subgroup included are well-differentiated grade 3 neuroendocrine tumors. This pathology is very tricky and can sometimes be misdiagnosed as poorly differentiated or brought lower than it is, like a grade 2 instead. So there is, and historically it was not included in pathology. So that's a very important group to highlight in the CABINET trial that evaluated cabozantinib. Now, what's interesting is cabozantinib was on clinical trial for patients who had received several other treatments. And so the comparison was to placebo because we did not have a comparison. And so it has unique side effects, namely increase in blood pressure. And so that's why I was talking about always looking at the whole picture. What other health issues might you have and what can we make worse if we're using a medication? Certainly, we don't have to do that. We have other options. But we're going to be using cabozantinib more and more for neuroendocrine oncology. When it was studied on trial, 60 milligrams was the prescribed dose. However, a majority of patients had toxicities and were brought down in the dosing. And actually, if we reflect back or if you talk to an oncologist who's been using it in the community for other diagnoses, you'll see that the lower dose is usually better tolerated. So for you, if you have any other side effects, you do have the opportunity for a dose reduction, but still having good tumor control. And that's certainly a conversation you can have with your oncologist. In terms of the hair changes, you may be more sensitive to dyes because you're on a cancer therapy, etc. So one way to get around that is to use non-permanent techniques like a spray that covers for the day and then washes out. Or if you wish to use something that lasts longer, a test patch first to make sure you don't have an allergic reaction to it because we don't want to add more side effects to your well-being.
That's a good tip. Absolutely. Thank you so much. Folks, we're in for a treat today. I appreciate you being so thorough. That is very helpful. And thanks, Len, for your question. Good to see your name. Next question comes from John. John says, PNET primary, resected 7 years ago, 6 metastases left in the liver. They are not growing nor multiplying, but diagnosed as not resectable. Octreotide injections are helping a lot. Would you recommend staying with this treatment or getting more aggressive with PRRT, embolization, et cetera, to attempt to shrink or kill the tumors?
Okay, great. This opens up a lot of concepts, actually. So the first, question that came into my mind while you were reading that is, have we evaluated this in a tumor board where you are being evaluated by a proper team, and we can bring in other treatments like surgery, interventional radiology, etc. And that is really incredibly important and something I highly value in our team, where we have multiple tumor boards per week, and we're able to bring an entire team for the patient without you going to 6 different clinic visits. So you had that, and what was determined is it's not resectable. That may be because of where the tumors are, where you may not have enough liver left to continue its job. It may be too high risk around vessels, etc. Now, the next point that is something that I work with my patients that we have to get comfortable with over time is stability good enough? And is that acceptable? And if we really look at well-differentiated neuroendocrine tumors that are indolent in nature, meaning they do not grow at a rapid rate, many of our treatments really achieve stability, and we're not going to see a 50% reduction in size. And that's something that we need to get comfortable with and accept, that we can make neuroendocrine tumors more chronic and coexist with your well-being over time. And the reason why we may not choose to expose you to higher risk medications is it makes sense to take on the risks of those treatments when we are in the face of a growing tumor, such that we are gaining benefit that outweighs those risks. And I think from what you're describing, you are feeling well, and your interim scans, which is really the best way to assess what are we gaining and achieving with the medication, is stable. And that is where we can be, and that is still a celebrated outcome. And you can hold on to liver-directed therapies, which we can talk about if there are any other questions, or PRT, which is really a very growing field for a time where there is a change in tumor behavior.
Thank you so much. Thanks, John. Speaking of, you mentioned multiple tumor boards a week, and thinking of the center that you have there at Moffitt, how important is it when we talk about tumor boards, multidisciplinary teams, et cetera, for this disease specifically? And more so, what advice do you give the patient that may live in a rural area, not near one of these centers? How important is it for them to seek out a specialty center like this?
Right. That's a really important question, and I think we have several ways to answer it. So I'm very lucky to work at a comprehensive NCCN designated cancer center, the only one in the Southeast. So we have specialists in every field that we would want for cancer therapy. And our tumor boards are quite large. And for example, if I describe our gastrointestinal oncology tumor board, our general one, it is a large group of surgeons, but we might have surgeons that only do pancreas surgeries, those that only do colon surgeries, those that do mesenteric and liver surgeries. So they're really quite specific, but that brings in a lot of expertise, and it heightens the chances of being able to do a surgery that may not be available to you in a less specialized center. But this also includes a group of neuroendocrine oncologists like myself. We have a team that's present, other medical oncologists, so that we can share experience and learn together. We have our genetics team. We have our clinical trial team, so that we are reminded you can offer this option. And interventional radiology. We have a radiologist that shows us the scans and walks us through them as a team. And pathology. So our pathologists show us the slides, and we're learning along with them, especially if we have cases where we've changed the diagnosis, which is very important in neuroendocrine tumors. So I have received patients with a diagnosis, and we've changed on our review and been able to offer a more specific treatment plan. So for neuroendocrine tumor in particular, I'm part of our North American Neuroendocrine Tumor Society, and one of our goals is to increase awareness within our communities, and this is to physicians who are seeing more neuroendocrine tumor patients, and so engaging with our community and being accessible. So our tumor board, for a patient who may not want to receive treatment with me in Tampa because they live far away, and they can have, for example, a somatostatin analog closer to home, 15 minutes down the street, my role there would be as a check-in point. Perhaps at first diagnosis, we would meet, I would review your care at tumor board. If we could add a surgery, perhaps you would come for the surgery with us, and I would partner with your oncologist who's able to provide care closer. And I think that is a very welcomed opportunity, and something that's really part of our culture in our cancer center to do so.
Got it. Thank you. Next question comes from Brenda. Brenda says, anything new on the treatment front for primary lung nets with metastasis to liver with no receptors?
Yes, and I think lung neuroendocrine tumor is unique because they don't reliably express somatostatin receptors, which is the target for somatostatin analog or treatments like radiotherapies with PRT. And we've actually shown that through our review for our patients for both typical and atypical lung neuroendocrine tumors. So a few minutes past, we talk about cabozantinib and the importance of having a dedicated population of patients with lung neuroendocrine tumors. Everolimus is certainly another studied medication for tumors that we cannot remove. But we can also borrow the experience from other primary sites, meaning from the clinical experience of neuroendocrine tumors that begin elsewhere other than the lung. And so one is a combination of oral chemotherapies and called CAP-TEM, so it's 2 different medications. I actually bring this in if I feel that I want to see some reduction in size because my patient is having symptoms. So that is something that we have shared our experience with, and that's another combination that can be used. Surgery and liver-directed therapies are still looked at when neuroendocrine tumors of the lung have moved to the liver. So that is certainly still in your resource list.
Got it. Sticking in the same general category of lung nets, Sandra says, do you treat dip neck at Moffitt?
Yes, dip neck can be quite difficult to understand and difficult for one to have because it can be quite symptomatic. So dip neck is clusters of neuroendocrine cells that make tumorlets. So tumorlets are less than half a centimeter, so it's not a large tumor, and it can be diffuse, meaning throughout the lungs, and can cause a very irritating and very symptomatic cough. Now, we want to monitor our patients with dip neck at least annually because some of these small tumorlets can develop into tumors, at which point we would look at potentially removing them. But for symptoms, we have shown that the use of somatostatin analog may help in decreasing the cough and the discomfort associated with dip neck. Now, this is not for treatment of it, but it's for addressing a symptom related to it. It's also helpful to have a relationship with a pulmonologist because the use of inhalers to help with airway disease is still very much applicable.
Got it. Thank you. Thanks, Sandra, for your question. Let me know if you have a follow-up. Next question from Nisi, I believe. Nisi, let me know if that's how you pronounce your name. Kind of a big and vague question, but I think that that we can address it somewhat. The question is, if you were diagnosed or if you are diagnosed with carcinoid tumors, will all new tumors also be carcinoid tumors?
So certainly if we are following you and with a history of a neuroendocrine tumor and we see something new, we want to prove it's related to that diagnosis because we don't want to miss a secondary diagnosis, whether it's another cancer or a non-cancerous entity. So we want to take steps to prove that it is related. And we can use something like a PET dotatate. And there is many ways to image neuroendocrine tumors. I'm just going to take a step back, Rain, and kind of cover PET for any new members in the audience. So we can use CT scan, MRI. That helps us understand structures. It helps us understand abnormal flow to areas that look malignant. And then over time, if we know what it is, we can measure size differences. So it's a very good way to follow a treatment control or treatment effect over time. And then PET scan really has become an umbrella term with different types of PET scans, and unique to well-differentiated neuroendocrine tumors is the PET dotatate. So I previously discussed receptors. These receptors are overexpressed or enriched on neuroendocrine tumors. You can think of them as spikes or antenna, and the PET dotatate links to those receptors and lights up. And so if you know that you are treating a neuroendocrine tumor and you find a new mass, for example, in the liver, you can proceed to a PET scan. And if it has those receptors, you can then have a discussion about this is a new tumor that is related to our known diagnosis of neuroendocrine tumor.
Got it. Thank you. Next question comes from Kathy. Kathy says, I have NETs of the lung and pleura, stage 4A, grade 2, started in lung and went to pleura. The pleura evades imaging. What new imaging is being used for hard to see NETs of the chest? My initial tumor was 0.6 centimeters when metastasized to the pleura, and I have hundreds of small tumors in my pleura visible in surgery, yet not on CT.
Yeah, you are not alone in that experience, and I've actually had to figure my way through with my patient in a very similar situation. I think we don't want to do repeat procedures to expose you to, and so a very helpful tool is to work with a tumor board, like thoracic tumor board, and have the radiologist engage, and they can really guide about what kind of CT, or if they know we're getting a CT for you uniquely, they may do it in a way that is more informative. We talked about PET scan not being as reliable in lung neuroendocrine tumors. If I were to guess by some of the wording you're using, it could be atypical, so less likely to have somatostatin receptors. However, if you have not had a PET dotatate, I still do obtain them, because if I can show that they're reliable for my patient, it could be a tool every once in a while to assess how much burden of tumor there is.
Got it. Thank you, Kath.
There's another concept that comes up with imaging, which is a very, very small tumor significant enough to make a big change in treatment, or is a small increase in size significant enough to make a big treatment change. And if we look at how we design clinical trials, we really want a substantial measurable change to then talk about let's change our treatment. And so sometimes if you can't get good measurements, you may look for other changes, like do you have fluid buildup that you did not have before that may signify progression even if I cannot measure it, and that's enough of a change to discuss the treatment change.
Got it. Thank you. And no, always continue to speak up. They don't want to hear me talk anymore. We're here for you. Folks, this is Luncheon with the Experts. If you joined us a little bit late or joined us very recently, welcome to the show, brought to you by CCF and NCF. We are here with a first-time guest, Dr. Menna Haider. Great questions so far and great answers, so keep them coming, and we will keep trying to get to all of them. Terry says, can you get NETs to your breast after a NET to the stomach? So I guess, can they metastasize to the breast? Or perhaps. I don't want to assume.
Yes, that's a very good question. And yes, neuroendocrine tumors can be first found in the breast, and then when you actually evaluate, you find where it started. And sometimes it's a misdiagnosis, because if you're focused on this was in the breast, it must be a breast carcinoma. And if the pathology review is not by someone who sees a lot of neuroendocrine tumors, it could be a missed opportunity. So absolutely, even small bowel NETs, I have patients with metastases or small nodules in the breast. In fact, you can have very subtle expression on a PET dotatate in breast nodules. And if that is the case, I always get a mammogram and investigate that, because sometimes I do find actual breast cancer not related to the neuroendocrine tumor, and the PET scan was what started the evaluation, so it could go both ways.
Got it. Thank you. Appreciate your question. Denise says, do you treat HNPGL, head and neck paraganglioma?
Yes, we have a program here at Moffitt. I work very closely in a different type of team than what I had discussed. So here, our patients are assessed in our endocrine tumor board. Our patients are first seen by endocrinology, who then kind of lead the further assessments. And so we work with our head and neck surgeons. My role on the team is when we are seeking systemic therapy. So for example, we cannot offer a surgery or there is recurrence. And that's why I pull in medications to best assist.
Got it. Thanks, Denise. Lynn says, if cabozantinib is lower down from 60 milligrams, does that hurt the efficacy of the treatment?
That's a really very good question, a common discussion in clinic. And so if we reflect back on how the trial moved forward, a majority of the patients required a dose reduction and still had benefit. And actually, if we look at all literature of medications assessed, we want to pay attention to what was the dose starting and how often were we decreasing the dose to toxicity, so we can be better prepared once it becomes in clinical practice about what side effects there are, and be empowered to do or make appropriate dose reduction. Because we want to be able to continue the medication And again, most of our experience in neuroendocrine tumor is that we want it to treat the tumor and for you to thrive and feel well. And a dose reduction can help us achieve that.
Got it. Thank you. Thank you. Next question from Yara. Took everolimus for 10 days, 10 milligrams a day. Creatinine level was 2.5 before everolimus and raised to, raised to 4.3 after 10 days. So I stopped it. Are there other possible treatments that can be used with this? Do you say creatinine? Is that, am I pronouncing?
I think. Creatinine.
Creatinine. Thank you. Are there other possible treatments that can be used with this creatinine level, in parentheses, EGFR is 16, and can I go back to everolimus with a lower dose?
So what we're describing is you started this once daily pill and your kidney function took a hit, if you will, and decreased. And so absolutely we would stop the medication. Here, the next step is to work with a nephrologist or a kidney doctor because the kidney function can improve over time with their help. And, the nephrologist or the kidney doctor has a set of studies that they do. And sometimes if they want to understand how to best serve you, they will do more investigative testing, including biopsies. I'm not saying that that's needed, but I'm highlighting the importance of working with a nephrologist who also works with cancer patients and is knowledgeable about these medications. And that's really a growing field and can be accessed. Thereafter, everolimus can be dosed lower. So you have an opportunity to have that discussion if the kidney function improves. But there are other medications that can be looked at as well that may have less effect to the kidneys. But the first step is to try to get the kidney function back or get a new, steady state for you that is improved from this decline.
Got it. Thank you. From Nisi, what specialists should we have on our team and how often should we meet if we have chosen a wait and see approach, which applies to a lot of patients here on the show?
If I were to guess, the wait and see, a popular situation might be a pancreas neuroendocrine tumor that's small and we're observing its behavior and have avoided a surgery to the pancreas in that setting. So it is dependent on the team that you're seeing. I will give you an example of how we work here. For us, it's the patient in the center and we're all focused, and then the medical oncologist is with the patient, and I pull in the team member we need at particular times. So the overwhelming majority would be following with me in clinic. And if I'm seeing, for example, a change in behavior, I may go back to tumor board or link you with the team member that I think best serves us. Could be a surgeon, could be nuclear medicine, etc. But that might be different, for example, in other centers where the surgery team takes the lead of observation, and then we'll bring in the medical oncologist for a change to address it.
Speaking of the wait and see approach, this is something I've heard countless times on the show, especially with newer patients. It can be quite frustrating to hear that as a strategy. Mm-hmm. You hear cancer, you're like, yeah, why are we not attacking this? Can you talk to me a little bit just about why that might be a choice that a doctor makes?
Right. So I talked about the concept of accepting and still finding a positive when we are stable on medications. And so the next concept that, I want to go in and say everything's gone, but we want to see where are we serving you best with treatment, whether it be a surgery or medication, and where are we just introducing side effects when you did not need that exposure. And so watch and wait could be a small, typical lung neuroendocrine tumor that has been there for 4 years, but ultimately you met with someone who biopsied it. So now we know it's there, but it hasn't changed in nature. We want to avoid doing surgery to the lung because there are risks for that. And it hasn't posed you a risk in terms of growth. Watching you offers you the best way to keep you safe so that you are being actively observed but without taking on the risk of a procedure that you do not need at this time to serve you. And so the same thing happens with, for example, neuroendocrine tumors of the pancreas. And we're seeing neuroendocrine tumors more because we're getting more scans, we're doing more scopes, and that might be the reason why we're capturing them more. And we want to intervene when we know that it serves you in terms of avoiding symptoms, in terms of avoiding a behavior of the tumor that can harm you in the future. But we also have experience and we have data that can really help us make informed decisions. And so for pancreas neuroendocrine tumors, if they're not releasing a hormone that's disruptive, if they are low grade, well differentiated, and if they measure quite small, our cutoff is 2 centimeters, then we have the option of seeing how is this behaving over time, and avoiding the risks of a surgery to the pancreas. So, no matter who is doing the surgery, there is always a risk. And we first don't want to do harm, and this is a situation where we can offer less invasive outlets.
Got it. Thank you. Denise says, what is the significance of disparity in dotatate SUV between a head and neck paraganglioma and a lung nodule with regards to metastasis? Is there an SUV level where a lung lesion becomes a concern, e.g., if an inoperable vagal para has an avid SUV in the 100s and the lung nodule has a mild SUV of 8 and is stable, is that an indication it is not a metastasis?
That's a great follow-up question from our previous discussion.
Right.
If we see something new, can the PET scan help? And so this is discordant, where we know a diagnosis and how it's behaving on the PET scan. We have another nodule that's behaving differently. And so it could be unrelated. It could be something else, but you're describing something that's been stable. And the lungs are a notorious place where we can have little nodules from previous infections, from previous inflammation, and many times they are monitored over time. So if this area is acting in a suspicious manner, I think it does warrant an investigation to understand what it is. But if you have historic CT scans, let's say, depending on how that timeline looks and it has not changed in nature, then it would be a nodule of the lung that could be monitored over time.
Got it. Thank you. From Samantha, what effects, if any, can lanreotide have on perimenopause?
I think we need to investigate this further and take a look, because we have differing symptoms at different ages and as patients are on it long term as well. And I would have to really look into the question to be able to give you an evidence-based answer. And it's sometimes tricky to understand symptoms that can mimic, for example, a functional tumor, and I'm concerned about that happening, but at the same time, my patient is perimenopausal. How do I tease out what's causing what symptom? And this is where trying to understand the best testing to understand a symptom and the culprit, so that we are not mistreating or overlooking another cause. In terms of lanreotide itself promoting perimenopausal symptoms or alleviating them, I don't have a good reference for us at present.
Got it. Thank you. From Shane. Hey, Shane, good to see you. Shane, cycle of PRRT needed to be reduced due to low neutrophil, 160 MCI versus 200. The SPECT scan afterwards showed tumor shrinkage when compared to the prior scan. Could this apparent shrinkage really just be due to less Lutathera used this cycle?
So we can zoom out one more time and talk about PRRT and Lutathera. So we previously talked about a PET scan that highlights receptors. We talked about somatostatin analogs being a good frontline or first treatment. And then PRRT is still addressing those receptors, but is also introducing radiation to the tumor cells. So it kind of acts like a Trojan horse, if you will. It links to those receptors and the radiation is released into the tumors. And you bring up one of the side effects that we might see, which is effects on the efficiency of the bone marrow. And so we can see our blood counts dip on treatment and then they recover. And sometimes we can have an understanding where there's a prolonged time of suppression of the bone marrow, meaning the recovery takes longer. And we have a couple of options when that happens. One is to give you more time to recover the bone marrow function, or the other, which is unique to each institution, and we certainly do this sometimes, is to adjust the dose a bit lower so that we're not bringing down that function as much. Now, Rain, correct me if I'm wrong, but I heard this was the third treatment, correct?
Third cycle of PRT, yes.
So you could also reflect that it is a cumulative effect now, not just that the third cycle is taking its effect, but now we have a cumulative effect. And for PRT, it is not fast to see a change. So for example, we may not see big changes in measurements early on, but we may see them a bit later. And I think that's the timeline we're seeing for you.
Got it. Hey, thanks, Shane. Oh, next question, folks. We got about 15 minutes left, so we're still going to keep plugging along. Okay, from Crystal. Is a single grade 1 NET well differentiated found in the terminal ileum enough reason to see a NET specialist? My GI doc has been giving me a lot of pushback saying specialists for this aren't any better. I have had a PET scan and it appears to be contained in my intestines, so I'm feeling optimistic about my upcoming surgery with a NET specialist surgeon and the symptoms hopefully going away. My GI doc said, don't get your hopes up about the symptoms stopping since all tests for carcinoid syndrome were negative.
All right, so multiple great points that we can discuss. One is what we're talking about here is a small bowel neuroendocrine tumor that is mature, well differentiated, and grade 1 of 3, so quite slow to grow. That doesn't mean it will not grow, and it doesn't mean it cannot move. And for small intestine starting points, a proper surgical resection is indicated, even if that is the only site on your PET scan. So the gastrointestinal tract in general is very interesting because it has different parts and they all have a different function, but they're populated with different cells, different microbiome. And even in neuroendocrine oncology, different primary sites, meaning the origin site, behave differently. So I might have different advice for one that starts in the duodenum versus the terminal ileum versus the colon or versus the appendix. And so your plan for surgery is what we would look at for you. You brought about carcinoid syndrome. Carcinoid syndrome is a set of symptoms that can be related to hormone release from neuroendocrine tumors, and it's a high level of serotonin production. And it can feel like diarrhea, it can feel like flushing, it can feel like drops in the blood pressure, and it can be quite disruptive. And I think what your physician is saying is it's quite localized. We often see these symptoms when we have a large bulk of tumor or involvement in the liver. However, you're going to have symptoms if you have something, in the GI tract. So if you have changes in your bowel habits, it could be from the tumor being there, and you might feel relief when it is removed. So, and you would have that feedback after you complete surgery. I think thereafter, I always tell my patients there are, the neuroendocrine centers are available at any point of your experience. And we are still very much applicable to your care even after you have surgery to learn about what does the pathology look like, talk about it, talk about what does surveillance look like for you and serve you best. And maybe even have a discussion about if this were to come back, how would we deal with it? So you have really a bird's eye view of what the future can look like for you.
Got it. Thank you. Another question from Yara. 3 months after the fourth cycle of PRRT, creatinine level started to rise up continuously. Could this be a side effect of the PRRT, or could it be from the disease itself, meaning or implicating that or implying that the disease is progressing?
Right. So the PRRT can have effects on kidney function, and there is an infusion that begins when we are planning to give the radiotherapy that is designed to protect the kidneys. And certainly, though, we can still see a creep up in the creatinine level, meaning that the function of the kidneys is affected. And this can improve with time. Again, I would bring in the importance of a nephrologist who can help tease out, is this medication related? Is there something else going on? One of my concerns in taking care of neuroendocrine tumor, I think it's every oncologist should think about this. We're dealing with something very important. It really takes center stage, and we don't want to forget the rest of the healthcare because we're dynamic beings. So we don't want to miss another culprit affecting your kidneys that we can understand and treat differently. So certainly PRT could contribute to that, and it can be better understood with the right diagnostics.
Thanks, Yara. From Lynn, any information or comments regarding CAR T-cell therapy? Have had many treatments over 7 years. Primary was in the PNET with Mets to the liver, and now a few bone Mets here recently.
Yeah, so CAR T is a new evolving treatment. You can place it under the umbrella of using the immune system, and we are actually looking at that. So we have a physician scientist on our team who's not in clinic, but she is in the lab, and she has been working on this concept. We're quite early on, but it is of interest in neuroendocrine tumor. CAR T therapy can have a lot of toxicity, and so we want to understand when we're designing cellular therapy that we're not affecting normal tissue, especially understanding the target that these cells would interact with and not affecting the function of, having inflammation in the brain, for example, as a side effect. So starting to understand a target that best fits neuroendocrine tumor and with the least toxicity is where we are at present. And we're not the only center working on that, but I think you should, keep your eyes and ears open for news about this development over time.
Thank you. Another question from Yara: does high serotonin level or high 5-HIAA affect kidneys?
This is a byproduct that we're measuring. The 5-HIA is a breakdown product of serotonin. And so sometimes that breakdown product being elevated is more reliable than spot checks on serotonin level in the blood. And I don't think that those are the culprits for changes in kidney function. However, if I were to think about a patient with high urine 5-HIA, they may be quite symptomatic. So are you having other insults to the kidney function, like carcinoid syndrome, where there's a lot of fluid loss and dehydration associated with it, with loss in diarrhea? And to pivot a little bit, we also don't want to forget another important organ that can be affected by this high level, which is carcinoid heart disease, where plaques can develop on particular valves of the heart. So that's what I start thinking about, actual organ involvement specific to those high levels. But there can be other mechanisms that come about, like dehydration, when we have a functional tumor that is not under control.
Got it. Thank you. Samantha says, I have unexplained iron deficiency anemia and regularly require iron infusions. Can my PNET be the cause of this issue, causing malabsorption, for example?
That's a great question. First, iron deficiency anemia can be due to blood loss, and that has to be evaluated. We've learned over the past years that we need to be sensitive to undiagnosed loss through the gut. So the first thing I would do is, after I've proven that the anemia is due to iron deficiency, because anemia really is a big umbrella term and can have different reasons, and there's a way to understand that it's due to iron deficiency, I advise to take a look at the colon and make sure that we're not missing any bleeding source there. Thereafter, if you continue to be iron deficient, meaning you're getting iron through your veins, you're getting 100% of that dose, but it's then being lost. So you're asking, could I not be absorbing it? If you are getting the iron through your veins, we're not worried about an absorption problem through your gut anymore because you're getting 100% of that dose, which means if you then become iron deficient again, are we losing the iron somewhere? And that's why I'm coming back to, is there a bleeding source or a loss of iron? So for example, if you have a colonoscopy and that's negative, then maybe upper endoscopy, because you can slowly over time lose blood or have a bleed that you cannot see with your naked eye. And further, if that is negative and you continue to be iron deficient, then looking at areas of the bowel that cannot be accessed through an endoscopy, meaning upper endoscopy or lower colonoscopy, like a capsule, a pill that has a camera and it kind of tries to see, do you have vessels that sometimes are bleeding or another source. But to answer your question, if you are receiving the iron through your veins, it has bypassed an absorption issue.
Got it. Thank you. Folks, we have just about 5 minutes left. We're going to try to get to a few more. From Jacqueline, is the effectiveness of lanreotide injections IM diminished if not given correctly, e.g. over a few seconds, over 20 seconds, or if given every 6 weeks versus 4 weeks?
The standard approach is to provide it every 4 weeks. Now, sometimes if we're having breakthrough symptoms, we may adjust the schedule. For example, on Sandostatin, we can go to 3 weeks, we can adjust the dosing. But I have some patients who feel that they want to have it spaced out, and we work on that together. Now, the experience of placing the injection appropriately is based on how many patients are treated at that center. And so there can be variation of experience when you're in a place where there's just a handful of patients with neuroendocrine tumor versus a center where there's a program and the staff and nursing are very used to using this medication. And there's a lot of nursing education who are administering the medication. And so we want it placed properly for the best absorption.
Got it. Thanks, Jacqueline. From Tasia, diagnosed 15 years ago, no active symptoms or carcinoid syndrome. Serotonin is still elevated, although primary was removed 15 years ago. What suggestions might you have at this point for a treatment plan?
We have done a fair job, but not excellent, at finding a good marker to find or to follow the behavior of neuroendocrine tumor. And so you're mentioning serotonin, and previously I alluded to that if it's incredibly elevated and I can correlate it with symptoms, it is helpful, but it may not be the most reliable test. And so I wonder if a urine 5-HA was obtained. And and also, is there? Have you, in your surveillance, has there been any suspicious activity in large lymph node nodules, etc.? But I would not proceed to put together a treatment plan based on the serotonin alone, because it can be elevated for other reasons and medications. And so I would first counsel you to get the urine 5-HIA, but go over the list of medications and foods to avoid prior so that we're not skewed, and perhaps follow that marker. It comes back to a prior statement where we don't want to expose you to a treatment if we don't know what we're treating, and I think a high serotonin without symptoms, without any source found on imaging, is not enough to try to treat, and it should be investigated a bit differently, like the test I mentioned.
I have a question from earlier. We were talking about tumor boards, and you said you had a pretty large one. What roles or positions on that tumor board are, I don't want to say abnormal, but less likely to be in a general tumor board? Meaning, I know some tumor boards that have nurse navigators on them or something like that. Are there roles that are outside of the quote unquote norm for tumor boards that you have there at Moffitt?
Right. I think because we're a comprehensive cancer center, we have a bit of a larger team. So One is the presence of our clinical trial coordinators, and I think that is very collaborative because we can be reminded about what slots are available. They're able to screen patients with us so that when you're meeting with your oncologist, you know what's available as a standard, what is available on clinical trial, and you have all your options really thoroughly evaluated. And we also have a nuclear medicine tumor board, which is a more recent development. And this is our meeting to look at PRT for our patients. So PRT, again, is that radiotherapy. I know we only have a minute, but I'll be quick.
No, it's fine. Yeah.
And it's evolving. It's evolving in terms of when to use it. So when this treatment was first evaluated and approved, it was to be used subsequent to somatostatin analog, but more recent clinical trials now have pulled it more upfront for higher grade neuroendocrine tumors like grade 2 and 3. And it's also, it's not the only resource for patients, so that sequencing question again. And so this nuclear medicine tumor board has really brought our NET team just to look at, are we doing the next best step for PRT here? And how do we plan it best in terms of timing for our patient? Because there is a lag time between meeting with nuclear medicine, getting it approved and starting. And we want to be strategic about that lag time. And when does it serve the patient okay? Or when is that lag time not acceptable? And so as the group meets together, it's really firmed up the planning.
Got it. Thank you so much. Just a couple of comments before we go. Eileen says, Dr. Haider is incredibly articulate in explaining all topics, very methodical and so easy to listen to this information. Brava. And followed up by Larry saying, what an amazing fount of knowledge. I couldn't agree more. Dr. Haider, thank you so much. This was incredible, and I totally agree. Very thorough and very easy to understand, which is not easy to nail both of those.
I want to thank everyone for your time. I know that everyone's on a different part of their day across, the globe. So thank you so much.
Absolutely. Appreciate you being here and hope to have you back again. And thanks to you all at home. As always, we hope this program helped answer some of your questions. I'll reiterate, reach out to ncf.net/support line if you have follow-up questions. In the meantime, you know that we will be back every 2 weeks. Stay tuned for summer dates because sometimes there's holidays, Labor Days, and Independence Days that might throw our schedule off, but you all know that we will announce it. Finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe.